discussion will be moderated by Dr. Manojkumar, consultant at Leo Hospital, Calcutta, and Dr. Melvin, assistant professor at Dr. Mupin's Medical College, Wayanad.
At the outset, I should thank the entire organizing team of MidCon 2025 for their wonderful arrangement. It's being the youngest branch of Kerala, but yet they have taken the challenge of organizing such a mammoth event, and they have done it wonderful. Then they really deserve a big applause. Okay, so my disclosures: I have no conflict of interest or no financial support. So I have been entrusted with the job of giving a brief overview of or generate some interest on the topic, like what is the impact of anesthetic agents on the developing brain. It's a huge topic and a bit difficult to understand, but I have tried my level best to make it simple and as brief as possible. So over the course of my lecture in the next 15 or 20 minutes or so, I will be going through the molecular sites of anesthetic action, mechanism of possible anesthetic neuronal injury, what we learned from the animal studies, and what are the observational cohort studies conducted in human subjects till date, and do we have really a neuroprotective agents now, and what are the future directions. So can you appreciate the slide? If you appreciate the slide, you can see that the maximum neuronal development, most of the components of the brain develops from the third trimester to the infancy. This pointer is not working. So except the ventricles, which is shown the blue line, all other components of the brain, the maximum neuronal development happens in the late pregnancy or immediately after the infancy. So that is the very crucial time for the neuronal development, brain development. So this is a time when the programmed cell death, even the programmed cell death is a path of neuronal growth and synaptogenesis, myelin maturation, and pruning of the nerves. So what are the molecular sites of the anesthetic action? To make it simple, you can say that basically all our anesthetic agents in common use acts either by enhancing the inhibitory neurotransmission or it reduces the excitatory neurotransmission. If you take any anesthetics, basically this is the two modes of action. And so consequently, it acts either an agonist action at the gamma aminobutyric acid, GABA A receptors, or it's an antagonist action at the N-methyl D-aspartate receptors. Basically, this is the two molecular sites of action. So what is the mechanism of anesthetic neural injury? If a molecule, if an external agent acts at the GABA receptors or neuronal NMDA receptors at the time of neuronal development, it can have a modulating effect on the neuronal development and growth, and it can cause a neurotoxic. It's a neurotoxic agent at that time. And Ikenomaidu et al. Way back in 1999 has shown that NMDA receptor blockade is causing widespread neurodegeneration in neonatal rats. And Jotek et al. Has shown that triple anesthetic exposure leads to long-term cognitive defects. So way back in early 2000 or in late 1990s, it has shown that anesthetic effects on the brain, it has got a harmful effect. So what are these mechanisms? It causes a structural damage, it causes the metabolic disruptions in the neurons and enzymatic activations. Physiological enzymatic activation is actually a disruption, and ultimately all these leads to disruption in the neurotransmission and neurointegration between the different segments of the brain. You need a good integration between the different regions of the brain, which may not happen if you give an external medications. So, what are these mechanisms of neuronal injury? Most important one is, couple of things are very important. One is neuroapoptosis. Neuroapoptosis is nothing but a programmed cell death induced by anesthetics. It may be a natural thing, but it can be accelerated by the anesthetics. And altered synaptogenesis. I have said that at the synaptic formation period is very crucial for the myelination and neuronal growth. When you have a drug which can disrupt this synaptogenesis and the maturation and pruning, it is a neurotoxic drug. And neuroinflammation, inflammatory response which can lead to long-term consequences, and mitochondrial dysfunction at the molecular level, disrupting cellular metabolism and causing oxidative stress. So, what does the animal studies? So far I have described rodent models only. The rodent models have shown that ketamine, isoflurane, sevoflurane leading to increased apoptosis acting through NMDA receptors, and benzodiazepines and barbiturates disrupting neuronal development through GABA A receptors. And nitrous oxide, midazolam, isoflurane and shown to affect spatial learning and memory skills. So, you have a good number of anesthetics which has shown harmful effects in the rodent models. Now, if you picturize these things, you have increased degree of neuroinflammation, increased autophagy, inhibition of neuronal differentiation, dysregulation of gut microbiota, myelination defects, increased ferroptosis, alteration in synaptic plasticity, increase in apoptosis and increased level of oxidative stress. Ultimately, these leading to learning and memory impairment, social impairment and deficits in fine motor skills. So, this is what we learned from the rodent models. Now, let us see what we have learned from non-human primates like rhesus monkey. This is very important because it has got a genetic, physiological and behavior similarity with the human brain. So, any negative effect is very alarming, and so we have found that ketamine, isoflurane, propofol and sevoflurane exposure can result in altered visual recognition, cognitive and behavior impairment in neonate rhesus monkey. So, the situation is very alarming, and in fact, British Journal of Anaesthesia took special interest to convey a meeting at Salzburg in Austria, and it was sponsored by British Journal of Anaesthesia. They looked into anesthetic and a special article has come. What they have discussed about the anesthesia induced neuroplasticity, effect of general anesthesia on neuronal network assembly, anesthetic effect on neurogenesis and anesthetic effect on synaptic density. So, whatever information they have gained at that time, they have brought a special issue which was addressed as anesthetic neurotoxicity, neuroplasticity and expert group report and statement based on BJA Salzburg seminar. It came in 2013. So, it became a subject of hot debate, and not only among the public, but also among the health professionals and health managers. So, FDA naturally took into action, and they have produced a warning to sedate or not to sedate, general anesthetic consideration in pediatric imaging. It actually came in 2017, and so far evidence was against using prolonged or repeated anesthesia in children under 3 years and pregnant women in the 3rd trimester unless necessary. So, they have said prolonged or repeated and unless it is necessary. These are two crucial words. So, you may ask, why don't we have a studies on the human subjects? It is not easy. A couple of previous speaker has said the Sugamadex, there is no evidence in FDA has not approved in late labor on neonates, because it's very difficult to conduct a human trial, a prospective randomized control trial. Who will explain to the mother, I am going to give you a drug, which can likely to have a neurodevelopment sequence in your newborn. Will anybody agree to it? No, nobody will agree it. So, you have only animals and we have only few human studies. They are mainly retrospective studies, and prospective randomized studies are not possible due to ethical considerations. And neurotoxic effects are species, dose and duration dependent threshold. So, we cannot extrapolate our results so far from the rodent and rhesus models to animals. That is the inference. So, 3 studies, there was a hot debate and 3 studies, panda, mask and gas studies came into picture. But all these studies are observational cohort studies. Panda is pediatric anesthesia neurodevelopment study, and mask is Mayo anesthesia safety in kids study. Gas is general anesthesia versus sedation study. So, let us look into the results. So, actually panda study looked into the association between single general anesthesia exposure before the age of 36 months and neurocognitive outcomes in later childhood. How did they do that? Basically, they matched a sibling matched cohort. That is, in the family with this almost the same genetic pool, they differentiated one child with the anesthesia exposure and the other child without anesthesia exposure. And basically all these studies looked into what you know as the hernio surgeries, herniotomy surgeries, because that is the one basically conducted in that age group. And results were published in Journal of American Medical Association in 2016. And they have shown that single anesthesia exposure before 36 months and neurocognitive outcome in later childhood. And they have followed all the children up to 8 to 15 years, and they have found that there is no difference in outcome between the 2 sibling groups. So, the children who have received anesthesia at the crucial time and those who have not received does not have a statistically significant difference in the neuronal outcome. So, that is a very positive thing to happen for the pediatric neurology, pediatric anesthesia. And the second one is Mayo anesthesia safety in kids study, mask study. So, what they looked, that was published in 2018, and what they looked into single and multiple exposure to anesthetics before the age of 36, 3 years, and on matched cohorts. That is, in the children within this group who has received anesthesia and those without exposure to anesthesia, and they followed up the kids. And they have shown that brief single anesthesia exposure was not associated with the defects in intelligence or in neurophysiological domains. But multiple exposure associated with a decrease in processing speed and fine motor coordination. And Corey, they didn't comment it very strongly, possible difficulties with the behavior reading abilities. So, the third human cohort study was the panda study, gas study, general anesthesia versus sedation. So, what they looked up into is basically randomized to receive either awake general anesthesia or awake regional anesthesia or general anesthesia again for herniotomy surgeries, and the results were published in Lancet in 2019. And it was a worldwide study, and it was conducted in 28 different hospitals, and it was on children born greater than 26 weeks were induced into the study. And what they have recruited actually 722 kids, and 363 were awake regional anesthesia and 359 for general anesthesia. And they have observed the neurodevelopment outcome after 5 years, and they have shown that under 1 hour of anesthesia does not cause any significant neurocognitive or behavior defects. So, what we have learned so far from the human cohort studies is that single or multiple exposure, single exposure may not affect intelligence quotient or scores. On the other hand, multiple exposures may have adverse effects on processing speed, fine motor abilities, social linguistic abilities, visual and motor integration, and motor skills. So, in defense of the anesthesiologists and the pediatric surgeons, of course, has come some few editorials that gas, panda and mask, no evidence of clinical anesthetic neurotoxicity. The comfortable truth is that likelihood that developmental anesthesia neurotoxicity may not exist in routine general procedures that occur in early life. Another update is published recently is in 2013, clinical investigations on anesthesia-induced developmental neurotoxicity, the knowns, unknowns and future prospects. What they have published is that updated understanding on the topic and expose the knowledge gap on the topic. Of course, we have to admit that there is no prospective randomized studies and there is definitely a knowledge gap on the topic and limitations of doing research on the topic and future prospects. So, the key findings from human trials is neonates for major surgery at risk of poor neural development outcomes, and there is strong evidence that a single short exposure may not impact neurodevelopmental outcomes, but weak and inconsistent evidence that anesthesia exposure is associated with later diagnosis of behavioral problems and weak association between anesthesia exposure and school performance or school readiness, though the relationship cannot be assumed as casual. So, the key findings in human trials is neonates for major surgery are at risk of poorer neurodevelopmental outcomes. And there is strong evidence that the association between exposure to anesthesia and some neurodevelopmental outcomes which are stronger when you have a multiple exposure. Okay. So, current recommendation is do not delay or alter surgery or a repeated procedure due to concerns over neurotoxicity if the delay is not in the child's best interest. So, you do not have to postpone the surgery or warn the mother, parents unduly saying that you are going to administer a neurotoxic agent. There is no need of it. And do not adopt an unfamiliar or unproven anesthesia techniques because you are concerned about neurotoxicity. Another neuroprotective agents which are coming, some research is going on, is that dexmedetomidine. And there is some positive findings that animal studies suggest a neuroprotective effect because they act through the alpha 2 agonist action. And there are clinical trials, ongoing studies evaluating this efficiency in humans on neurodevelopmental outcome. And xenon is another agent which has been tried for neuroprotection against isoflurane or nitrous oxide anesthesia, and clinical trials on birth asphyxia association has shown favorable outcome. So, practical consideration is risk assessment, benefits versus potential neurodevelopment risk, minimize the exposure, and you can use the lowest effective dose and shortest techniques, duration, and alternate techniques. Always we nowadays use multimodal analgesia. Can you appreciate someone doing caudal technique for the herniatomy? So, when now the anesthesia is mostly multimodal anesthesia, just like multimodal anesthesia, you always combine interfacial or regional anesthesia with the general anesthesia, so that you can reduce the dose of anesthetics. And neuroprotective, future direction is neuroprotective strategies like dexmedetomidine, xenon, and of course antioxidants and anti-apoptotic drugs are being trying. Long-term studies, you have to know beyond the childhood what is the effect of these agents on neurodevelopment, and mechanical studies, exact pathway of neurotoxicity we should know. So, takeaway is human data are reassuring for a single brief exposure. Anesthesia itself may not be harmful, the context, duration and frequency exposure may be crucial. And you never delay a medical necessary surgery and ensure optimum anesthesia care. And you need continued research for safe pediatric anesthesia practice. So, how will you counsel the parents if they ask you the same question? Is the anesthesia your anesthesia is going to be harmful for my child? If the mother comes at the third trimester or early childhood, you can always say it has got a very, very low risk, or there is no major risk as per evidence we have gained so far. So, thank you for your patient listening.
Thank you, Dr. Rajesh,
Thank you, sir.
Rajesh, that was an excellent talk on the brain development or the effect of anesthetic agents on brain development, particularly from a few months to 3 years of age.
Thank you.
Basically. And in RCC, we have a lot of patients, like children, coming for radiation and MRI procedures, CT MRI procedures. So these patients, we are giving ketamine, small dose of ketamine and small dose of propofol. Ketofol, a combination of propofol and ketamine. And they have radiation may extend for up to 1 month, 25 to 30 fractions. So is there any harm in using, or which is better to use propofol? Because whether I don't know whether that's also advisable to give propofol in small children like infants and all. So is it which one will be better from the literature? What you have found out for anesthesia in these children? These children are aged from 6 months to maybe 2, 3, 4 years. So which will be better? Yes, either propofol alone or a combination of ketofol or a ketamine alone. And another thing is dexmedetomidine, the role of dexmedetomidine. Can we use that as because some neuroprotective effect is seen? So is that good for instead of using propofol or ketamine?
Thank you, Venu, for the comments. Actually, till now, with the evidence we have gained so far from the animals or non-human primates, we cannot say that either ketamine is better or propofol is better. Because both these agents act through GABA A and NMDA receptors. Okay, so basically the mechanism for neural injury is basically because of agents which acts on the GABA A or NMDA receptors. So you have a molecule which has got a different path. So they have shown that dexmedetomidine has a better neurodevelopmental profile compared to ketamine or dexmedetomidine. Actually, there is another study which I have not shown because the recruitment completed only in 2023. That study is known as TASK study. TASK study. It is in Australia. So it will take another at least 10 years for the results to come. So they have what they are trying is, in one group they are giving a standard anesthesia with the sevoflurane, and in another group they are using dexmedetomidine to see that reducing the concentration of sevoflurane propofol, whether it will be beneficial for the neurodevelopmental outcome of the children.
Children like 1 year, 2 year old, that age.
That's interesting. FDA doesn't approve dexmedetomidine for the nasal route. Okay, off-label we are using dexmedetomidine for transnasal because FDA, for that matter, they don't approve any drug through the nasal route because of the fear that it can pierce the cribriform plate and go directly into the brain. So off-label it has been using extensively, and you can see reports in the British Journal of Anesthesia or the anesthesia, but never in the anesthesia or analgesia. It is very unlikely you see. But there are reports and it's being used.
So can we use, is it nasally, can we use dexmedetomidine instead of giving propofol and ketamine?
That's what I said. Ketamine may be written, but dexmedetomidine is extensively used. Even we have postgraduates. We have postgraduates using their thesis study on the nasal route.
Children. Okay. So what dose for nasal route?
Pardon?
What is the dose for nasal route dexmedetomidine?
Dexmedetomidine, the advised dose is around 2 microgram per kilogram body weight for the sedative dose, but you have to use 3 or even more than that. Usually we use through this thing. Nasal spray.
Spray. Atomizer spray. Okay. It's available at dexmedetomidine?
Yeah, atomizer. That name is mucosal atomizer device.
Okay. That is available. Dexmedetomidine is available.
We have.
Okay, we'll use that.
I can send you the pictures.
Okay. Thank you.
Thank you, sir.
Thank you, Dr. Sid.
Actually, I want to say that in this conference, first registration is from Rajesh sir.
Thank you.
Actually, and after, when we thought about the topic, Swarna madam, everyone, we have no confusion then to whom we should entrust this topic, because this topic has to go in deep with this research topics, papers and everything. None other than our own chief editor, to whom we should give it.
I don't know, I have justified for your confidence in entrusting me.
And he has already told that the research not yet to be published, that it's going on. And from the topic itself, when the mothers come to us and ask the same doubt, whether it's okay with the child, and pregnant ladies come to us and ask whether it's okay for the child in utero, we will say, okay, don't worry, you are in good hands.
Yeah, definitely, you have to say like that only.
But now I have a confidence that I can say the things with the backup of research papers. Thank you, sir.
Thank you, thank you.
Thank you, sir. Now I invite Dr. Manojkumar to the stage to felicitate Dr. Rajesh. Next, I invite Dr. Sachin onto the stage to felicitate Dr. Manojkumar and Dr. Melvin.
Bashi.